sir, are you ready?
Yes, I'm ready.
We are live on YouTube. We will start in a minute. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 20C, which is Transfusion Medicine. We are streaming live from PGI Chandigarh via Kolkata. And this is one of our first lectures in transfusion medicine, and the topic of the day is whole blood, blood components, and blood derivatives, including collection, processing, and storage. And to talk on that, we have somebody who's an expert in transfusion medicine, Dr. Krishan Dhawan. He's an MD in transfusion medicine from PGI Chandigarh. Presently, he's an associate professor in the Department of Transfusion Medicine at PGI Chandigarh. He's got multiple awards. The awards are he's got an award as a PG Fellowship Award at ISBTI in 2006, and the Bronze Medal for Research Work in 2008. Harold GUNSON Fellowship Award of ISBT in 2011. Fellowship Award from International Plasma Fractionation Association (IPFA) in 2017. He's got multiple publications in peer-reviewed international and national journals. He's a reviewer of various journals, namely AJTS, IJHBT, IJPE, and IJMPO. His areas of interest is quality assurance and blood components and clinical transfusion medicine. Before I ask Dr. Dhawan to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Dhawan, sir, please share your screen and let us start.
Okay. So, my screen is visible, sir?
So just make it full screen, please.
Okay. So now...
Absolutely fine. Please go ahead.
Okay. So I am audible also?
Yes, sir. Very loud and clear. Thank you.
So at the outset, I would like to thank Dr. Anita Tehlan and Dr. Nadeem and the Pursue team for providing me this opportunity. So I'll be talking on the topic of blood components, and PGI I'm working on in this area from last 1 decade. So I have experience in this, and I'll be sharing my experience and my pictures from my lab. And this this is a very extensive topic, so I have compressed it and started from the basics. And I will go slowly, and I'll try to explain you the basics of blood component preparation and what are the advances in the field. So the first thing you should know about blood transfusion is that it is a chain of events which starts with blood donor, and then comes the blood collection, component preparation, then we test the blood, which is very important part for the TTIs. Then we do a cross match with the patient, then the blood is shifted to the patient bedside, and finally the blood component is transfused to the patient. So the outcome in the patient is dependent on all these steps and the quality performed in these steps. So it is a chain of events. So the strength of the chain is as strong as the weakest link. So we have to maintain the quality in each step so that we can get a favorable outcome. So all these steps are very important. So we'll be dealing regarding these 2 steps in this lecture, and the rest of these steps may be covered in other lectures. So the first thing we'll be discussing today is whole blood collection. So the basic concepts of whole blood collection. This is also a process where we first select a donor by some criteria like age, their weight, hemoglobin level, and all the history taking. So that is also a separate topic, but we'll be discussing mainly about the other steps like selection of the blood bag, selection of the vein, preparation of the donor arm, phlebotomy, and finally successful blood collection. So these steps we will be discussing here because these will directly impact the quality of the blood component which we are preparing. So the volume of blood which can be collected from a donor. So there are two standards. One is Indian standard. It says that around 8 to 9 ml per kg body weight of blood can be taken from the donor. And addition to this, we can collect the pilot tube sample for testing also. There's another standard called AABB, that is American Association of Blood Banks. So this is a prominent standard which gives standards for everything in blood transfusion services. So they say that we can collect 10.5 ml per kg of body weight of blood from a donor, including all the samples. So the maximum blood we can draw is 10.5 ml per kg. So these are the two guidelines. So in India, so blood transfusion services is a licensed facility. So the Drug Controller General of India give a license to the facility. So they give some not the guideline, but the rules which have to be followed. So these are the minimum things which have to be followed in specific country. Like in US, it's FDA. In India, it's FDA, Indian FDA. So that is headed by Drug Control General of India. So they say that if the donor weight is 45 kg, we can collect 350 ml, and if the donor's weight is more than 55 kg, we can collect 450 ml of blood. And for apheresis, we can collect from donor who is 50 kg. So these are the two collections eligible in India, that is 350 ml and 450 ml. So basically the 450 ml blood we collect from donors who are above 55 kg and healthy, and we try to prepare all the components including platelet from this collection. So these are the first collections in the morning, and the 350 ml collection we usually do from the donors who are prone to adverse reactions, and there are some other reasons. Like from female donors we usually collect 350 ml of blood because we do not prepare platelets from female donors. We only use red cells, and the FFP prepared is diverted to fractionation because females can have anti-HLA antibodies because of multiple pregnancies and can lead to a transfusion reaction called TRALI, transfusion-related acute lung injury, that maybe you can study in the next lecture, which we will be having on 3rd. And then donors who have taken aspirin or any NSAIDs, which can directly affect the quality of platelet component, we usually do not prepare platelets from this kind of donors, and we collect only 350 ml blood. From all elderly donors who are, so we can collect up to 65 age. So from the elderly donors, we usually collect 350 ml, and blood donation after routine hours, like if the collection is taken after maybe 4, 5 p.m., 6 p.m. or late evening, we collect in 350 ml because we usually do not prepare platelets from these collections. So these are the 350 ml collection. So the 450 ml collection is the main collection from where we prepare all the blood components. So then comes the selection of the blood bag. So the selection of the blood bag depends on multiple factors, including I have discussed. So other factors are how many platelets are required on a particular day, how many leukoreduced red cells are required on a day, or how many bags we have of particular type in our inventory to be used. So all these things matter. So we have a charter where the donor weight, the history of an NSAID or aspirin intake, type of component we want to prepare, and the type of bags we can use. So all these things are considered and the collection is taken. So basically the component laboratory, they guide the blood collection laboratory or blood collection center to take particular type of bags because they want to prepare platelets or do not want to prepare platelets, and other factors the collection center they factor in, and then they collect the blood bags. I'll be discussing in detail about the blood bags because that is very important. That is very important for the component preparation part. So next comes the selection of the vein for phlebotomy. So this is very one of the most important critical steps for successful blood collection and component preparation. So a good phlebotomy will only give you a good blood component. So the both arm of the donor must be checked to find a central good caliber fixed vein. So there are many veins in cubital fossa. So these are cephalic veins, these are basalic veins, and in the center we have median cubital veins. So these median cubital veins are the prominent veins which should be used for this phlebotomy. And there are two veins, one is this and one this. So this vein is also a fixed vein. So the biceps tendon fixed this vein. So this is not a mobile vein. So the vein is fixed. So whenever you prick, so it goes directly, and there is minimal trauma, and the pain is also lesser in the center. So, and we should never try the side veins because they are painful also, and sometimes lead to under collection also, and the component quality is also lesser because it takes more time to collect. And we should prefer more palpable vein than more visible vein, because more palpable veins are usually fixed veins, so they do not move, and the venipuncture is clear, and there is minimal activation of coagulation or platelet activation during collection. So we have a good quality blood component prepared from this. So the next step in blood collection is preparation of the donor arm. So the cubital fossa need to be very well prepared. This is also very critical for component preparation, because if this step is not done properly, our blood bag can have a bacterial contamination. So the bacterial contamination of the blood component is the most dangerous thing, most dangerous outcome one can have in a patient. So to avoid that, we need to take utmost precaution in this. So we need to clean 4 to 5 centimeter of the cubital fossa area. So there are two type of there are many methods in this. So the most commonly used methods are the one-step procedure where 2% chlorhexidine, gluconate, and 70% isopropyl alcohol are used, and this is applied for 30 seconds, and we have to wait for 30 seconds to act, and then we can do the phlebotomy and try that it is air dried. So there is another step which is used in if we are going to blood donation camps, where there is a lot of cleaning is required in the cubital fossa for some of the donors. So the 3-step procedure is used. For first, we apply 70% isopropyl alcohol. So that will remove the dirt and grease from the cubital fossa. Then we apply povidone iodine. So that is a main disinfectant which will kill all the pathogenic organisms, and then we can clean this up so that it does not stain the donor's clothes. So, and then allow 30 seconds for the final preparation to act, so that the area is properly prepared. So after the area is prepared, we should not touch the prepared venipuncture area. And before doing the phlebotomy, we have to apply a tourniquet or blood pressure cuff. So the pressure in the cuff should not be more than 40 to 60, because it takes around 8 to 10 minutes for blood donation. So if we have higher pressure, so the donor can have a discomfort, and the component quality also, the potassium levels will rise in the blood, so component quality also deteriorates. So we have to have this minimal pressure, so that the collection is also good and the donor is also comfortable. So if we need to repalpate the vein before pricking, so we can use the area above the clean area. So we should not touch the clean area, and the phlebotomy site we have to choose is free from skin lesions or scars. So there are sometimes these donors are voluntary donors, they come for 25, 30, 50, even 100 donations. So they have small scar each time they donate. So each time we have to find a fresh skin point, because these lesions, they can harbor pathogenic bacteria which is difficult to clean even. So this is also very important. So all these steps which is done to prevent bacterial contamination of the blood component, so these are very important, and So that's why I told in first time. So the first part of the chain, which is blood collection, will directly affect the quality of blood component, which we will be discussing later. So the donor need to pump and the blood get collected in around 8 to 10 minutes. And if it takes more than 15 minutes, then we usually do not prepare blood components, because in such long time, because of slow flow, there is activation of platelets also and coagulation factors also. So the blood should be collected well within 10 minutes for successful preparation of components. So another important thing you should know is needle position. So this comes with experience. So we need to have a single bolt clean venipuncture for a good collection. So the needle should be appropriately inside around 1 to 2 centimeters, and it should be bevel up so that there is a good flow. In case it bevel down, it can touch the lower part of the vein, or if it's not properly inserted, or if it goes too far. All these conditions can lead to under collection, bad donor experience, and even if the collection is done, so the quality of the component will be very poor. So this the needle positioning and the phlebotomy is very critical for the component quality. So finally, after doing all this, we have a blood collection. So a blood unit is collected. So we have two collection volumes, as I told you. We have 350 ml plus minus 10%. This is the range. So we can 350 ml plus minus 10% is considered a valid blood donation. So for 450 ml collection, 450 ml plus minus 10%. That is 45 minus, that is 450 into 495 is 405 to 495 ml of collection is considered good for preparing blood components. So these bags have CPDA. So I'll be discussing about this. What is CPDA? CPDA is a antioxidant preservative solution. So the volume of the whole blood in case of 350 ml collection is around 400 ml, and for 450 ml is around 515 ml. So this is usually collected in single. If we want to keep it as whole blood, which is not usually done, but we need only a single blood bag. We don't need any other bag. And hematocrit of this bag is around 30 to 40%. Hemoglobin content of this bag, if we collect in 350 ml, it's around 40 to 45 gram per bag. And depending on the hemoglobin of the donor, it can go up to 70 grams per bag. So this is very important. One very important concept in blood transfusion is that each blood bag is a batch. So blood is a drug as per Drugs and Cosmetic Act, as per the licensing authorities. It's a drug which is produced by a blood center. So each whole blood is a new batch. So the qualities in the whole blood or a packed cell depends on the hemoglobin content or hemoglobin levels in the donor and the volume collected. So all these components are variable. So like in other pharma medicines produced, so there are 1 lakh maybe tablets produced in one batch. So here each unit is a batch. So the testing and the quality have to be very critical, so that we have to be on our feet to ensure the quality of each unit, because it can affect the patient outcome directly, because each unit has different characteristics in this. So the hemoglobin content, as I told you, that can vary from 45 to 70 grams. So one bag can raise 1 gram to 2 gram of hemoglobin. But these whole bloods are usually used in massive transfusion and in military setting. So another concept you should have is what is antioxidant preservative and what is red cell additive solution. So as I told you that around 49 ml in 350 ml bag and 63 ml in 450 ml bag, we have CPDA. So it is actually called CPDA 1. So this 1 stands for the generation, because they have tried CPDA 2 also. So finally the CPDA 1 was giving better results. So it is so 1 does not mean anything. It is just a generation. So The CPDA have four constituents: citrate, phosphate, dextrose, adenine. So for the beginners, I want to tell them that what is the purpose of each component. So the citrate, it is trisodium citrate, which acts as anticoagulant because blood will otherwise clot in the bag. Then we have phosphate, which acts as a buffer to maintain pH. Then we have dextrose, which act as a substrate for energy for glycolysis to happen. So adenine is raw material for ATP generation. So once we store bags with the blood with CPDA1, the shelf life of PRBC or whole blood is 35 days. And nowadays we have another solution called red cell additive solution. So once we prepare components, so this CPDA goes into the plasma bag. So we just have red cells. So we need some solution so that our red cells are suspended and they get energy. So we have this SAGM solution, which is most commonly used in India. There are many variations or newer solutions available, but this is most widely used. So it has components like saline, adenine, glucose, and mannitol. So saline is suspending solution. Adenine, as I told you, is raw material for ATP. Glucose is substrate for energy. The only different solution it has is mannitol. So what mannitol do is it maintains the red cell membrane. It goes inside the cell also and coats the cell also. So it stabilizes the red cell membrane. So the shelf life of the RBCs increases by 7 days. So the shelf life for the PRBC is in SAGM solution is 42 days. So this one concept you must have. So then before coming to the actual preparation of blood components, I wanted to convey you some basic concepts about why we need to prepare blood components. So usually patients require specific component of blood for treatment. So other component get wasted, like patient require red cells or plasma or cryoprecipitate. So other components, if we give, will only give a volume overload to the patient and no benefit will be there. So one is that specific component can be given to the patient. Second is that lower transfusion reaction. So this volume overload was very big problem with the whole blood. So many of the patients get a volume overload. That is called reaction these days. That is TACO. TACO is transfusion associated circulatory overload. So this is biggest killer these days from the blood. If we do not recognize that patient is already overloaded and we transfuse a full unit or we transfuse whole blood or 2-3 whole bloods, patient can develop this TACO and patient can die also. So other reactions like allergic reactions can happen because of plasma proteins. So in components we can remove plasma and suspend the bag in SAGM solution, as I told you. Then febrile non-hemolytic transfusion reaction. So these happen because of the white blood cells in the bag. So we can remove those white blood cells also in component preparation. So another benefit is rational use of scarce resource. So one bag can be used for treat many patients. So our inventory got multiplied. So in PGI we collect around 60,000 units of whole blood and we prepare around 1.5 lakh blood components. So our inventory get increased, and another very important scientific point is that different blood components have different appropriate storage and different shelf life. So if we keep a whole blood, the whole of the whole blood will expire in 35 days. But if we prepare blood components, we will have different shelf life. Like if we add SAGM, the shelf life of red cell will be 42 days. The platelets will expire in 5 days, but the FFP can be stored up to 1 year. So all these benefits will be there. So the last benefit, which is very important benefit, is that preparation of plasma products. Like from fractionation, we can do fractionation of plasma, which I'll be discussing in the last part, and prepare albumin, IVIG, and factor. So this is a very important thing which was missing in our in Indian context. Earlier we used to have whole blood only, but it is rapidly the picture is changing, and we are now moving towards blood component preparation universally in most of the centers. So this now we have indigenous albumin fractorate. Otherwise, we used to import fractorate earlier. So now we have this. So this will generate a lot of revenue. So nowadays, this can generate revenue for the blood center also, and they can improve their services because of revenue generated from these fractionation components. So now we come to the requirements for component preparation lab. So earlier we have a blood bank. So then government set up the blood component preparation unit. So what are the additional requirements for component preparation lab? So the additional requirements are adequate space. So we need additional 50 meter square space in the blood bank dedicated for component preparation, because this is actually a factory in the blood bank where all the components are prepared. So dedicated space is required. A trained manpower is required. So BSc MLT with 1 year experience in component lab, or DMLT with 1 year experience in component lab. Specific requirements are there for the technologists to work in component lab. We require specialized equipment like refrigerated centrifuge. So before starting, we require a license from regulatory authorities. So this is also important that, as I already told you, that it is a licensed facility. So our license must mention what all components we can prepare before starting the component preparation. And last is the quality control program. So we have to have a quality control program to ensure the quality of each blood component we are preparing. So this is just wanted to share the picture of our blood component license. So we have a license for preparation and distribution of whole blood, packed red cells, fresh frozen plasma, platelet concentrate, cryoprecipitate, even plasmapheresis, platelet pheresis, leukapheresis. So all these things should be listed, and this is issued by Drug Controller General. So this is our license of a blood bank or a blood component preparation unit looks like. So we require additional equipment like weighing scales, double pan balance, refrigerated centrifuge. Laminar airflow was required earlier when we had an open system, and now things are closed system, but this is still a requirement as per DCA. So deep freezer, platelet incubator, agitator, refrigerator, water bath. So all these things I'll be showing you during my talk. We can have additional equipment like stripe connecting device, gamma irradiator, and cell separator for apheresis. So all these equipments are required. So before starting a component separation unit, we need to procure all these equipment. So, and then the most important thing is we require blood bags from where in which we can prepare blood components. So with different blood bags, we can prepare different blood components. So this first one is the basic bag, which is called single blood bag with CPD. So this is usually 350 ml. So this contains 49 ml of CPD, and we can collect the bag, test, and this will be a whole blood. The basic bag where we can prepare blood component is double blood bag, and where we can prepare two blood component, packed red cell or FFP, or packed red cell or PRP, which is platelet rich plasma. And advanced than this is triple blood bag, where we can prepare all three components, packed red cell, FFP, PC, or packed red cell, CPP, and cryo. So CPP is cryo poor plasma, and cryo is cryoprecipitates. So we can prepare three components from triple blood bag. So this is sort of a first generation bags used. So then we have even better blood bags where we can remove white cells from the component, so that we can decrease the transfusion reactions like febrile reactions in the patient. So we have these quadruple blood bags where we can prepare all three components, and we can remove 1 log WBCs also. 1 log is around 90% of the WBCs can be removed with this kind of bag. So this comes in two configurations, top and top quadruple blood bag and top and bottom quadruple blood bag. So in top and top, all the bags are attached on the top of the bag, so all the component can be separated through this. I'll be showing you the pictures how we do this separation. And the top and bottom bag is that this is the mother bag. So the bag in which we collect blood is called mother bag, and all other bags are called transfer bags. So we have 3 transfer bags and 1 mother bag. So we collect blood in this, centrifuge this, so we can separate out plasma and platelet from above, and we can separate out red cells from the below, and the red cells get directly stored in a sagum solution. So these are the quadruple blood bags. So what are the benefits of these bags? We will have 1 log leuko reduction, like 90% of the WBC will be removed. The shelf life of the RBC will increase. The hematocrit of the RBC will decrease so that it can be transfused easily. We can have more platelets in these bags, better quality platelets, more plasma, because we are removing all the plasma, we are suspending the bags in sagum. So all these benefits are there from these bags. And the even higher generation bags is called quintuple blood bag. So what addition they have is inline leuko filter in these bags. So what happens is that red cells come in this transfer bag 3 and sagum is there. So we shift the sagum from this leuko filter. So this is a white blood cell filter, and this get primed, and we will have a sagum bag. And then finally what we do is we hang this bag upside down, and all this pack red cell, they come through this filter into this bag. So this is the process being done. So this is a pack cell and this is getting filtered. So this will be a leuko-reduced bag. So what happened in this is that we get a 3 log leuko-reduction of PRBC. I'll tell you what is 3 log leuko-reduction. So 3 log leuko-reduction is 99.9% of the white blood cells get removed from these pack cells. So all other same benefits like 42 days shelf life for RBCs, hematocrit of 55%, which is lower than the PRBCs, more platelets, better quality platelets, more plasma in these bags. So these are costlier bags, but they will give us many layer of benefits for the patient. So all these bags are available, and currently we are using quadruple and this quintuple bags for our patients. So these are not only the these 5 are the basic types of bags. So if we take a product brochure from specific firms, we can find out the bag configuration in so many types. So there are minor changes. So we can have so many configurations. So bags can have many more configuration, but these 5 are the basic types. So this is a quintuple bag, this quadruple bag, and then triple, double, and a single blood bag. Then we come to the basic definition of blood component versus blood product. So this is a very interchangeably used term, which is blood product. So blood component is the components which we prepare in a blood center from by centrifugation, which is packed cells, FFP, platelet concentrate, cryoprecipitate, or even WBC concentrate or granulocyte concentrate. And blood products are the products which are manufactured by plasma fractionation process in the industry. So we send the excess plasma, the recovered plasma, which is not used for therapeutic use. So we send that, and that can be subjected to many processes, many chemical processes, and we can have albumin, plasma protein fractions, intravenous immunoglobulin, and coagulation factors. So these are basically called blood products or plasma products, and these are called blood components. But these are very frequently interchangeably used terms. So now we come to the principle of blood component preparation. So half an hour I will have. So we have come to the middle of the talk. So I have 50 slides. So I think I am on 24 slides. So we are in time. So blood component preparation. So we came to the core topic of today's, which is blood component preparation. So the basic concept of this blood component preparation is the differential centrifugation. So we apply centrifugal force to the blood bag, but because of the different specific gravity of different cellular components in the whole blood. Like red cell have a specific gravity of 1.080 platelets. Platelets have a specific gravity of 1.030. Plasma have a specific gravity of 1.020. And the white blood cells have specific gravity of 1.070. That is just below the red cells. So once we apply a force, so these components get settled according to this scheme, like red cells, white cells, platelets, and plasma. So this middle layer, which is white cells and platelets, is called Buffy coat. So this is plasma, or also called platelet poor plasma, and this is packed cells. So we use different mechanical maneuvers to separate these depending on the blood bag we are using. So another important definition we should understand in component preparation is RPM versus RCF. So RPM is revolutions per minute and RCF is relative centrifugal force. So the force applied by the centrifuge in the form of gravity or in the form of G is called relative centrifugal force. So this is a more academic term which is used because this does not require the size and the brand of the centrifuge to be known. So we can just say that 5000 G or 5000 G force will settle the component like this. But the RPM is specific for a centrifuge. So like we have a specific brand of centrifuge. So in the lab we talk in the terms of RPM, like 3000 revolutions per minute. But 3000 revolutions per minute with a radius of 29 centimeters will generate this much RCF. So we should be knowing. So some people, they confuse between RPM and RCF. So they tell RPM, but usually if you are writing a paper or if you are conveying to some other laboratory or you are discussing with inter-laboratory, you must use RCF as term. So I'll be discussing all the things in RCF, but in the lab you can use RPM also. So there is a direct relation between RCM and RPM. So there is a formula, we can devise this, but no need to calculate this. The centrifuge itself calculates it and tell you the RPM and RCF for the specific centrifugation speed. So we have two centrifugation programs mainly. One is called hard centrifugation and another is called soft centrifugation. So the hard centrifugation is where we apply a RCF of 5000 G for 5 minutes at 22 degrees or 4 degrees. So what happens with this hard centrifugation is that, as we seen, that all the cellular components, they settle down and we have just plated poor plasma on the up as a supernatant. But for the soft centrifugation, it is five times lesser in the term of speed for the force is only 1000 G. So what happens is that the red cells and the WBC settle, but the platelets, they remain suspended in the plasma. So what we get is platelet rich plasma here and a packed cell. So we have two layers, platelet rich plasma and packed cells. We don't get Buffy coat in this. So then there are two basic component preparation methods which you know, and one of these is called PRPPC method. So what happens in this PRPPC method is we give a light centrifugation first and we convert our bag into red cells and PRP. So as shown earlier, so this will happen. So what we do in this is that we express all the PRP into the another bag up to the red cell margin, because these red cells are loosely packed because we have given just a light spin or soft spin in this. And what we do is that this PRP along with another transfer bag, we give a hard centrifugation, and then the platelets, they get settled on the surface of the bag, and the platelet poor plasma we shift into another bag. So we finally have red cells, plasma and platelet concentrate through this PRPPC method. There's another alternate method to this is BCPC method or Buffy coat method. here we do a opposite spin. We do a hard spin first. So in PRPPC method, we have done a light spin first. So in this, we are doing a hard spin first, where we layer all the cells on the bottom, and we have a PPP or plated poor plasma on the as a supernatant. So what we do is that we separate the red cells and the plasma according to the bags attached, and the top and bottom bag we take out the red cells from the below and plasma from above, and the Buffy could remain inside in the bag. So what we do is that we keep small amount of plasma for the platelets, and we give a soft spin to the platelet, this Buffy coat bag, and finally we have a BCPC. BCPC is a Buffy coat derived platelet concentrate, or a platelet concentrate which is prepared by a Buffy coat, and a residual WBC. So these WBCs will remain in the mother bag, and we can discard these bags. So this kind of separation will give us a 1 log leukoreduced bag, so which will be helpful to prevent febrile reactions in the patient. Even the platelet quality in this is good because we are not centrifuging platelets at high speed, so platelet activation is lower. We will have more amount of plasma in this because we need not to leave any plasma for red cells in this type of study. So this is the double and triple blood bags being separated. So this is called manual component extractors, where we centrifuge a bag, then we put this bag into these plates. So this is a glass plate against this steel body. So this has a spring. So this plate compresses the bag. We just need to open the seal, and the component will come into these empty bags. So this is a manual method where we separate double and triple blood bags. So, but these are the automated or semi-automated component extractors, where we don't have to do anything. We just have to put the bag and put the tubes through these sensors, and just press OK, and all the components get separated. So red cell will come from the lower into the lower bag, and the plasma will go from above, and the platelet bag and the Buffy coat bag will be there, and we can give a second spin. So these are the two type of component extractors we have. So the key important points I just want to revise up to this is that in component preparation we should be knowing what is RCF versus RPM, hard spin versus soft spin, like 5000 G versus 1000 G, and PRPPC method versus BCPC method, where we give first soft spin and then hard spin, and in BCPC method we have to give first hard spin and then soft spin. So these three things you must remember from this lecture. So then I come to the storage part and some specification part of these blood components and some advanced blood components. So first we come to the red cell component. So red cell component have many variations. Like, so this is a basic packed cell which is prepared from double and triple bag, like packed red blood cell which is suspended in CPDA. So then we can have second packed red blood cell, then we can prepare leukoreduced packed red cell by filtration. We can have washed packed red cell, we can prepare pediatric PRBC, we can prepare irradiated PRBC also. So I'll be having individual slide on these things. So packed red cell, as I already told you, so this is prepared from double and triple blood bag. So the volume is 220 ml if we are preparing these bags from 350 ml collection, and 280 ml around if we are preparing from 450 ml bags. The expiry is 35 days and 42 days depending it's in CPDA or SEGM, and hemoglobin content is more than 45 to 50 grams, and it can go up to 70 grams depending on the donor's hemoglobin. So we can divide these bags into smaller units by connecting empty bags to these bags, to this adult bag, and divide these bags into a pediatric bag. So we can divide this 280 ml bag into 90 ml 3 bags, and we can, so that our component is saved. So in neonates they require just 50 ml transfusion or 60 ml transfusion, so we can provide this. And even for the premature neonates where they require even 20-30 ml fraction and over a longer period of time, because they are premature because of multiple sampling. They usually require transfusions frequently. So what we can do is we can create a dedicated donor unit, where what we can do is we can have a fresh bag, divide it into maybe 5-6 axial small pediatric bags, and we can reserve all these bags for the same patient. We can reserve the FFP and the platelet also from this unit for the same patient, and we can reduce a donor exposure in this. So this is being practiced in pediatric hospitals, so that the donor exposure to the multiple donors can be avoided by making these pediatric bags. Then we come to the leukofiltered PRBC. So the concept of leukofiltration is also very important in this new concept. So whole blood bag have around 10 to the power 9 WBCs per bag. So there are 1 billion WBCs are there in a whole blood bag, so which frequently lead to febrile non-hemolytic transfusion reactions. So if we prepare a pack cell, so the same amount of WBCs are there in this. So, but if we do a Buffy coat depleted bag by BCPC method, as I told you, by in quadruple bags, what we can prepare is that we can reduce the WBC content from 1 billion to 10 crores. So there's 90% reduction. So what happens with this is that febrile reactions, they go away, but there are still some reactions like HLA elimination, CMV transmission. All this can be avoided if we reduce the WBC content from 1 billion to 1 million. So this is achieved by 99.9% reduction. So this can happen only with this filter. So what happens is that we hang these pack cells, and through these filters, the final component will have only 0.1% of the WBCs in the original unit. So the WBCs will reduce by 1000%, and these bags will hardly cause febrile reactions or other reactions to the patient. So there are various methods for producing these leukoreduced bags, as by centrifugation, like Buffy coat removal, filtration, even washed red cells they remove, and WBCs, freezing and thawing of RBCs. So sometimes we can freeze the red cells by glycerolization for 10 years, and once we thaw it, we will have a leukoreduced product. And by apheresis, if we prepare components, usually apheresis plated concentrate, they are already leukoreduced. So as I already shown you these things in the previous chart, so these are the WBC content of the various type of bags. So if we require a 10 to the power 6, we need to have a leukofiltered or apheresis product for by preparing leukofiltration. By using a leukofilter, we can reduce the WBC count less than 1 million. So this will be a leukoreduced bag. So there are many indications for this kind of product. So one important indication is to prevent HLA elimination, then transmission of leukotropic viruses like CMV, Epstein-Barr virus, for the patients who are prone to this, like immunocompromised patients or premature neonates. So all those patients will require a leukoreduced blood bag. And to prevent febrile non-hemolytic transfusion reaction, to prevent transfusion-related acute lung injury, and even transfusion-related immunosuppression. So these are the advanced transfusion reactions which can happen with a normal blood bag, which will not happen with a leukoreduced blood bag. Then we come to another advanced blood component called normal saline washed red cells. So some of the patients, they develop multiple severe allergic reactions. So patients who get frequent transfusions, so they get severe reactions with blood. So they develop reactions with the plasma protein from these bags. So what we can do is we can wash these red cells with around 1000 ml of normal saline, and This can be done by manual methods, or we have now FRSS systems also there to do these processes. Excuse me. So there are additional benefits of this washing with normal saline. One is we can have 1 to 2 log of leukoreduction also here. We can remove electrolytes and antibodies with this process also. So at the end of the red cells are suspended in additive solution or normal saline. So because this is an open system, we are adding saline, removing saline. So the expiry of these bags is usually 24 hours at 4 degrees, and the final product have protein content less than 0.5 grams. So this is the quality check. So we can see that this is the supernatant from the after doing a first wash. So we usually do 3-time wash in this. So we add saline and then centrifuge it and then remove the saline. So this final supernatant is almost clear saline comes on the top of red cells. So what we do is we remove this saline, add another fresh 100 ml of saline, and then give this back to the patient. So these are the indications for normal saline wash red cells: recurrent severe allergic reactions, IgA deficiency, recurrent febrile non-hemolytic transfusion reactions, PNH, atypical HUA patients, and sometimes to remove excess of potassium also. If we want to give an older bag for exchange transfusion, we have to do this washing. So another advanced blood component is irradiated blood component. So what we do in this is that we treat the red cells or the platelets by a gamma irradiation. So these are the gamma irradiators, which are cesium or cobalt, or sometimes in newer technologies have X-ray irradiated also. So what they do is they cause double-stranded DNA breaks in white blood cells. So even after leukoreductions, the white blood cells can cause transfusion-associated graft versus host disease. Like you must have listened about graft versus host disease in solid organ transplant. Similar to that, we can have graft versus host disease in bone marrow transplant also. But similar to that, we can have graft versus host disease with red cells or whole blood transfusion because of active T lymphocytes present in these bags. So who are prone to this are bone marrow transplant recipients, congenital immunodeficiency patients, premature infants, intrauterine transfusion, and also first degree relatives when son is donating for the mother or father. So in that one way actually a match can occur. So this can lead where the graft, which is a packed cell, or the T lymphocytes transfused through the packed cell, can cause a graft versus host disease in the recipient. So this is a very serious reaction with around 90% mortality. So in these group of patients, we usually treat the bag with 25 gray gamma irradiation and then issue the bag. So then we have platelet concentrate. So we learned about the methods of preparation: PRPPC method, BCPC method, FRSS platelet concentrate. Now we can pool the Buffy code platelet. So that is called Buffy code pool platelet concentrate. That is a newer type of platelet concentrate. So some specification about these components also I'll be quickly telling you. So the volume of this component is around 50 to 70 ml. So the unique is that these components, the platelets, they are stored at room temperature, 20 to 24 degrees. So they are not stored at 4 degree. The shelf life is only 5 days, and so the bag usually contains 50 billion platelets per bag. So once we preparing bag from for 50 ml collection, so they contain around 50 billion platelets. So there's another type of platelet concentrate called apheresis platelet concentrate, where we require a kit and a apheresis machine. So in this procedure we do is we connect the donor directly to this to the kit attached to this machine, and there's a centrifuge inside this chamber, and the machine draws the blood, centrifuge it, and keep on collecting the platelet. So here we can collect up to 6 to 8 times the platelet collected in a whole blood bag. So this is a bigger bag. So in this we have 50 billion platelets. In this bag we can have 300 billion platelets per bag. So this will increase around 6 times the platelet count in the patient. So these are being preferred, but this comes with the cost. The cost of these bags is around 8 to 10,000 in our country in India. Then we come to the fresh frozen plasma. So what is fresh frozen plasma? So fresh is that it should be prepared within 6 hours of collection and frozen below minus 30 degrees centigrade. So in India it is minus 30 degree. So we can go below this, but it should be at least minus 30 degrees centigrade. And the volume is around 150 to 200 ml, and the shelf life is 1 year in this. So what we have in this bag is 1 international unit per ml of all the clotting factors. So to preserve these clotting factors and to reach this deadline of 6 hours, what we do is we prepare the components quickly within 4-5 hours, and what we use is this blast freezer or snap freezer. So there are 2 plates in this. So these plates come around to minus 50 degrees centigrade. So what we do is we layer the FFPs on this surface. It holds the FFP and it snap freezes within 30 minutes. These FFPs reach below minus 30 degree and all the factors get logged, and we get a good quality fresh frozen plasma for 1 year. If we transfuse this FFP, this will give rise to rise in all the clotting factors in the patient. Then we have another blood component called cryoprecipitate. So this is a unique component prepared from the FFP. So FFP, where we have a empty bag attached to this FFP, where we are not preparing platelets, we are only preparing FFP and an empty bag is there. We label these bags as cryoprecipitate and cryopoor plasma. Then what we do is that we thaw these bags at 4 degrees centigrade and then put a hard spin to this. So at 4 degrees centigrade, what happens is that these factors, fibrinogen, factor 8, von Willebrand factor, and factor 13, they get precipitated. So they get precipitated and we express out the cryopoor plasma into another bag, the empty bag, and these precipitates and around 15 to 20 ml of plasma. We freeze it again below minus 30 degree and store it for 1 year. So we have this component called cryoprecipitate. So this is around 15 to 20 ml. The shelf life and temperature is same 1 year below minus 30 degrees centigrade, and it contains fibrinogen, factor 8. So this is a concentrate. So this is very useful in massive transfusion patients, in PPH patients. This is now being used for liver transplant patients. So this is a very important component in in a trauma setting or in multi-specialty hospitals. Finally, to complete the list, we have a granulocyte concentrate. So this is very rarely used, but this can be prepared by apheresis method or pooling the Buffy coat. So I told you that we discard the Buffy coat because this contains granulocytes. So in some patient, it causes fever or other reaction, but in some neonates or patients who are not responding to antibiotic therapy or have very low granulocyte or neutrophil count. So in those patients, we have to give granulocyte concentrates also to control the infection. So there we pool the granulocytes from 10 donors. So the granulocyte content of these bags is around 1 in 10 power 10 per bag. The volume is around 200 ml. So this contains a lot of red cells also. The shelf life for this is only 24 hours at 22 degrees without agitation. And this bag must be irradiated because this contains a lot of T cells. So this can cause TAGVHD in these immunocompromised patients. So those T lymphocytes, they get their potency get decreased. So there is no TAGVHD if we irradiate these bags. So this is the final blood component, which is granulocyte concentrate. Now we come to the last trench of this lecture. That is blood product or plasma product. So these are so we have source plasma for this. So one source is recovered plasma, which is plasma prepared by whole blood by component preparation, as I shown you, but not used for therapeutic use. And other is by apheresis. So some of the centers, they they just collect plasma by apheresis for this kind of component. So they shift this plasma to the industrial units, the plasma fractionation units, and they prepare all these components. So I'll be briefly discussing about the principle. So this is what is there in the plasma. So the plasma contains around in gram per liter around 30 to 40 grams of albumin, immunoglobulins, fibrinogen, all these factors, and the factor proteins also. So these all can be separated by the principle of differential solubility of proteins. So all these are proteins, so they have differential solubility, differential interaction of protein with solid media by chromatography, or differential interaction with the physical field. So they exploit all these field physical and chemical properties like charge, isoelectric point, size of the protein, and they separate it out by cryoprecipitation, by organic solvent ecosystem, by ion exchange chromatography, by immune affinity chromatography. So all these techniques get applied on the plasma unit. So what they do is they have big containers with 500 liters or 1000 liter capacity, where they put around 2000, 5000 units of FFP, and they cool it, and then they process that. The first step they do is cryoprecipitate. So similar to what I told you, that at 4 degrees the fractionate fibrinogen they get precipitated. So they separate out these fractions, and then what they add is they add 8% ethanol to that, and they change the temperature. Then first fraction comes which contains factor 13. Then they change the percentage of ethanol to 25%. Then second and third fraction comes where we have immunoglobulins, and then fourth and fifth fraction comes where we mainly collect the albumin. So I visited one plasma fractionation center, so I clicked some photographs. So this is a cryoprecipitate, a big cryoprecipitate raw material from where they will separate out the factor 8 by chromatography and other techniques. So these are big IVIG albumin bags from where they will do packaging. So this is final product testing. So this is a class A facility where no contamination can happen to these products. So this is a full pharma industrial setup where these products are manufactured and then produced to sent to the market and used therapeutically. So with this I come to the end of my lecture. Thank you very much for your kind attention. So this is my email. You can send your queries to me, or we can have queries on the WhatsApp or that Telegram group also.
Thank you, Dr. Dhawan.
Thank you.
Very extensive lecture and very detailed out all the components, blood and its components, along with the fractionation materials like albumin and the rest of the immunoglobulins and all that. Very, you can stop sharing, yeah, so that we can see you. Right. Let me see if there are any questions on the YouTube. If there are any questions on the Google Meet, then people can just unmute and ask directly to the expert.
So this was an extensive lecture. I tried.
Yes, it was very extensive, and you have compiled it very excellently, very nicely. In fact, all what is required has been, talked about. This can just go on, but only the relevant things which are very important has been discussed.
Just to ignite, basically, if you want to read THGSD, maybe you can read it. So in third, you will be listening from Dr. Lakhvinder about transfusion reaction. So you will be better able to relate these things. What I told you, all the components, he will be telling about the reaction. So this is all in the chain. So every effect have a final outcome in the patient. So
correct, absolutely. One is connected with the other. Absolutely fine.
Yes.
Absolutely right. So I see no questions on the YouTube. So Dr. Dhawan, thank you so much for this wonderful lecture. I would request you to please share the PDF. We have a Google Drive in which all the PDFs are uploaded for the students to refer to when they require.
Yes.
We will be sharing with you the video, the recorded video of this as well. It will also be there on the YouTube for future reference and convenient viewing. So thank you, Dr. Dhawan. Thank you so much for your time and your effort. We will definitely like to have you back here on some other topic on transfusion medicine because, as you can see, you are an expert there. So we will discuss with you if you can get time. And then thank you, Dr. Anita Tahlan, for arranging Dr. Dhawan to be here on this platform. It's an honor for us. So
Thank you, sir. Thank you, ma'am, for the opportunity. So this helped me also for revising all my concepts. So
correct, right,
thank you very much.
right. Take care then. Good night. Bye bye. Take care. Bye. God bless you. Bye.
Thank you.